Good evening. My name is Lewis, and tonight we're going to be talking about the pathophysiology of shock. All right. So, if I had students here, I would start off my class with a concrete experience. So, something to elicit a thought in their heads to try and drive home the importance of what they're about to hear. So the concrete experience that I would do to start off, I would take about 5 to 10 minutes to establish the scenario and then facilitate a discussion between the students about that, about the scenario, but to drive home that the importance of the class. So this concrete experience I would start off with would be a patient who has a GSW to the left side of his lower left side of his chest, upper left abdominal area. So, could have numerous things going on there, numerous different types of shock potentially going on there. He's would start off conscious in the scenario and then begin to deteriorate, and then have the students try and identify the different differentials they would have going on there and the different pathologies as far as the shocks go. In my short instructing experience at this point, students would, an EMT or paramedic, they would have some A&P knowledge and some knowledge of what shock is. They might not know what we're about to talk about, but they have some idea to contribute to this discussion in this class in some way, this CE. And then after I finish the scenario and we do our discussion, then I would dive into the class. So at this point, we had just finished our CE, concrete experience. All right, so shock is very simply defined. We want to keep it very simple as hypoperfusion. So hypoperfusion is basically where the cells are starved of oxygen. Okay, that's important because our bodies, our cells, when they go through cellular respiration, they're producing energy, ATP, all that stuff. There's two basic processes that they go through for that. So you have aerobic and anaerobic, right? So aerobic and anaerobic. So with our aerobic respiration, all right, this one obviously needs oxygen, all right? And when the cells are doing this, it goes through the whole process, the Krebs cycle, all that stuff, and in the end, you end up with 36 ATPs. And your body and your cells and muscles use all that for energy. In anaerobic metabolism, that is when your body is starved of that oxygen, it has to produce that energy somehow. And long story short, in that anaerobic process, you only get 2 ATP. So it is far less of a efficient process than aerobic. On top of that, you end up with the byproduct of lactic acid. So that lactic acid obviously causes an acidic environment in your blood, and that causes a whole other set of problems that we'll talk about in a little bit. So when we're going through this, right? So when perfusion decreases, okay, and you have less O2, and that's when you switch over to your anaerobic metabolism or respiration. Sorry. All right. And then that creates your byproduct of your lactic acid, which leads to acidosis, which leads to cell death. All right. So why is all that important though? So we have our, especially when we're talking about trauma, shock associated with trauma, we have our, what is now our lethal triad, and which soon will become in more updated trauma classes and literature, the lethal diamond. So in those you have acidosis, coagulopathy, and hypothermia. And our lethal diamond is the same, they just add in hypocalcemia as well. So all these processes are necessary to maintain our homeostasis and contribute to this shock physiology. So in our hypothermic environment, for example, your blood is it contributes to a lack of clots forming. So all these processes contribute to this shock physiology. All right. So what does that look like on our patient? So one point to drive home, especially when we're talking about our vital signs, is blood pressure is a late sign. All right, that is very, very important because a lot of people, when they're talking about recognizing shock, like to focus on the hypotension, but that is a late sign. All right, so some earlier signs that we're going to be talking about, we have our tachycardia. All right, so when our patient is becoming tachycardic, it's a way for the body to compensate. So again, we have our hypoperfusion. So our cells are starving of oxygen. So your body is trying to find ways to compensate for that. So tachycardia, it's starting to pump that blood around, trying to pump it more efficiently to get that oxygen to the cells. All right. We might have some pale skin, some diaphoresis, some altered mental status. We're going to see a lot of these things before we see our blood pressure changes. That's important. When we're talking about that, these signs help us differentiate in between our three basic stages of shock. So you have compensated, decompensated, and refractory. So our compensated stage. So the body is still in some way able to keep up with whatever the issue is that is going on. So if there is blood loss, for example, it's still able to compensate for that lack of volume by doing things like speeding up the heart rate, getting oxygen, attempting to get oxygen to those cells. Our decompensated shock is when your body is no longer able to do that. That's when we start seeing our lower blood pressure. All right, that's why it's a later sign. And then our refractory stage of shock, of course, is when you're basically to a point of no return. I think there's like a 60% mortality rate or something once you're in that refractory stage. So early aggressive intervention is important when we're talking about our different types of shock. All right. So we have 4 different types of shock that we're going to be talking about. So you have hypovolemic, cardiogenic, distributive, and obstructive. All right, so hypovolemic, right? So that's a lack of volume or lower than normal volume. All right, we have different types like dehydration, okay, or blood loss. All right, and then so different causes of that hypovolemic shock. All right, this is our the most well-known, most recognized type of shock, the traditional type of shock, where that we're all used to treating and recognizing at the very basic level. So that's what most people think of when they think of shock. That's what I'm trying to say. So then you have cardiogenic shock. So there's some sort of pump problem. With the heart. So usually MI, heart failure, issues like that. Our distributive shock. We have our sepsis, anaphylaxis, things like that. And then our obstructive shock is our tension pneumo, or like a cardiac tamponade. All right, so one of the biggest takeaways from any shock class you ever take is all these problems have different causes. They'll have some different, maybe some different vital signs, especially when you're talking about like neurogenic. But in the end, it's all the same problem. The cells are starving. They need oxygen. That is the root cause of all of this. And our goal is to try and get those cells oxygen, at least until they get to the hospital. We need to get oxygen to those cells. So our treatments should revolve around trying to get oxygen to those cells. So one of the best treatments out right now for hemorrhagic shock is giving blood. Big new protocol in EMS. I wish my system had it. We don't yet, but giving blood, right? Because in our traditional protocols, treatment pathways is 2 large bore IVs and a ton of fluid. The idea was to raise the blood pressure and the volume and keep things circulating, but we now know that could potentially be harmful. So one of the biggest reasons, blood carries oxygen. Normal saline or Ringer's does not. So getting that oxygen to those cells, using treatments that help make that happen. So and going back to our lethal diamond, okay? We have our hypothermia again. Our hypocalcemia. Our coagulopathy. Our acidosis. All right. So going back to talking about our hypovolemic, our hemorrhagic patient. At the beginning of the class, we discussed that in our hypoperfusion state, we have less oxygen getting to the cells, which causes that anaerobic metabolism or respirations, which causes a buildup of lactic acid, which causes cell death, secondary to the acidosis. So there's that, right? Now, going back to our traditional treatments, okay? Normal saline and lactated Ringers. Our normal saline pH, the average pH of normal saline is going to be 5.5. And for ringers, we're looking at about 6.5. So if you're, not only does that saline and ringers not carry oxygen, which is further contributing to our anaerobic metabolism kicking in, but is also acidic compared to our blood, right? Because our blood has a normal pH of 7.35 to 7.45. So both cases are less than that, than our normal pH, which is making everything worse, potentially. On top of that, our normal saline, our ringers, unless you work for an agency that has a very nice truck with some fancy equipment, is probably usually most agencies sitting in a cabinet at room temperature. So now you're sticking a fluid inside of a patient who is already in a hypoperfused state with room temperature fluids that are acidic, that don't carry oxygen. So that contributes to this lack of oxygen and this hyperperfusion. It just doesn't make things any better. So that's what we're going for with that. All right. So again, pathophysiology of shock. Going back to our scenario, we had a GSW patient, and their wound was lower left, like chest, upper left abdominal area. So we have a couple different potential shocks, types of shock that could occur when you have a GSW in this area. So big things we're looking at is we have the spleen in that area, very vascular, and could potentially lead to hypovolemic shock. All right. We also obviously have, depending on how high in the chest, we could have some lung involvement. All right, that pleural space, some compromise to that pleural space. We could have a pneumo. That could lead to a tension pneumo. And as we talked about, that is your obstructive shock. All right, so what's happening with this patient? So we'll say on initial contact, their ANO times 4. They have pale skin. Their heart rate is about 110. Their BP, we'll say, is 110 over 80. All right. So at this point, they're in compensated shock. All right. Their heart rate's gone up. So body is trying to compensate by that lack of volume, and their blood pressure is able to maintain because of that, right? Because once this stuff happens, when this injury occurs, part of the reason we have this, you have this sympathetic response, right? When that happens, that's what causes your heart rate to go up, okay? That's also can cause some nausea or vomiting, because what happens when your sympathetic nervous system kicks in, right? That's your fight or flight. Your parasympathetic is your rest and digest. So just to review that from what you guys should have already learned. So that's what causes the nausea and vomiting, because the sympathetic nervous system has a inverse effect on your GI tract. So parasympathetic, we have an active GI system. Sympathetic slows it down. So I had a AMP instructor one time when she was teaching the sympathetic and parasympathetic nervous system. She talked about a way to remember the sympathetic is sympathetic to an emergency. You're getting chased, caveman getting chased by a saber-toothed tiger. What does your body need to survive in that moment? And it's not your GI tract, obviously. That's going to slow down. So, but that is why we might have a shocky patient, a patient in compensated shock, who is nauseous, maybe vomiting. That's part of that sympathetic response. All right. We also have pale skin. So why do we have pale skin? So we have pale skin because when you get these injured states, your body starts trying to compensate. One another compensatory mechanism is to shunt blood to the core, to all the important body parts, and organs, which essentially your body wants to protect the heart and the brain primarily. So majority of your shunting is meant to protect those, not just those two, primarily those two organs. All right. But when that shunting happens, that's what causes our pale and diaphoretic skin, is that lack of circulation secondary to the shunting. All right, so when we start looking at our physiology of shock, we can start to understand why we have some of these symptoms, why they're occurring. All right, and of course, we talked about already, but once this BP drops, all right, so say this is our initial vitals, and then we're bumping down the road to the trauma center, and all of a sudden our BP drops to 80 over 60, and heart rate maybe goes up to 140, all right, and now they're altered. They're only oriented to themselves, all right. So that's when we're starting to get into our decompensated shock. So maybe that spleen got nicked, and now we're bleeding out, and that's what's causing us to move into a decompensated state. So the body's worked hard, it's tried to keep up, it can no longer keep up and compensate for that lack of oxygen. So again, this injury this the physiological response to a lack of oxygen. All right, doesn't matter if we're talking about any of these different types of shock: obstructive, hypovolemic, cardiogenic. Doesn't matter, distributive. In the end, it's all trying to get oxygen to those cells. Those cells are starved of oxygen, and they need oxygen, or they're going to die. The cells are going to die, and you start getting into organ failure, and then, of course, your patient dies. So, so that's what we're trying to do with that, is recognize these different patterns and what's happening with the body during these shocky states. All right. So, in summary, all right, shock is hypoperfusion. Which is oxygen starved cells. All right, at the cellular level, oxygen is not being provided to those cells. When it's not provided to those cells, they have to shift to an anaerobic respiration or metabolism in order to provide energy. But because of that lack of oxygen, the anaerobic metabolism, it's not as efficient, and so we're only getting our 2 ATPs and our lactic acid, which is the most important part of this, because then that contributes to our acidosis, which contributes to our cell death. And of course, acidosis is part of our lethal triad or diamond that we talked about, further contributing to that coagulopathy, that inability to clot. All right, and we have our 4 different types of shock. It's our cardiogenic, our distributive, our obstructive, and our hypovolemic. All right, and the different signs with that. And then we have our compensated, decompensated, and our refractory stages of shock. And we want to obviously try and avoid getting to this refractory stage, right? Because we have something like 60% mortality if we get to that stage. So early aggressive shock treatment, early recognition, right? And that early recognition, that compensated shock, right? That pale skin, right? Secondary to the shunting. That nausea, secondary to that sympathetic response. Our tachycardia, trying to get the oxygen to those cells, trying to compensate for that lack of volume. All right, recognizing these early signs before we get to our low blood pressure in our decompensated state, because that's too late. We want early aggressive treatment, and we don't want to contribute to that lethal triad with things like a whole bunch of normal saline or ringers. Now, that's not saying that you can't give that. Obviously, if that is all you have, you know, that you do what you got to do. I mean, but we don't want to dump so much in them that we're contributing and making this lethal triad worse. All right. Yep. So that is my class on the pathophysiology of shock.